back to listen to the show. My guest for this episode is Dr. Jeremy Rossman, who is a virologist. Now, Jeremy has already been on the program on episode 8, and I'm very happy to have him back on. And again, I'll thank all of you listeners for coming back to the show. I know there is quite a bit else going on in the world today, and as Jeremy and I discuss in this episode, the pandemic is still raging on and is still a very, very severe issue of immense consequence. So this still warrants much attention. Now, I feel this episode is very much a continuation of the last one, and Jeremy and I continue on discussing vaccines for the most part, as well as a couple other pertinent issues. So, please enjoy. Cheers, guys. All right, so our first returning guest, Jeremy Rossman, is back. How have you been doing, Jeremy?
Good. I guess I have that dubious pleasure of the one that comes back for more here.
Absolutely. I think you get that honor. So I think we have quite a bit to talk about today. I think before we get into one of the bigger topics, I just want to run over a few things that have happened as of late and what your thoughts are on them. First, what have you made of the big spike in cases in Seychelles?
Yeah. So this is a very interesting recent development because this is a country that had an extremely productive vaccination campaign. They have a large percentage of their population that was vaccinated with 2 doses for a large number of people, and now they're actually having an outbreak. And so, this raises a lot of questions of, are we getting new versions of the virus that are evading the vaccines enough that you can actually have an outbreak with a vaccinated population? How much of the infection in the country is due to people that have not yet been vaccinated versus people that are? And then, what happens with the different vaccines? So I'll sort of dive into all of these components just a little bit. So, the first part is that, we hear a lot about this idea of herd immunity, this idea that, once you get to a level of vaccination of the population, some people are saying, maybe 70% or so, that you really won't get outbreaks of the disease anymore, that it'll really stop that transmission and it'll really protect the whole population, even the portion of the population that hasn't been vaccinated yet. And the problem is that, of course, we don't know if that's actually possible with COVID. It might not actually be possible. More people you vaccinate, the lower the transmission is going to be. That's pretty clear. But we might never get to that point where there's that level of immunity that stops all transmission and protects that remaining portion of the population. And so here you're getting sort of almost a little mini trial of that. But it's important to remember that they did not have, that critical threshold of, say, arbitrarily 70% of the population vaccinated with both doses. So they weren't at that point where if herd immunity was going to work, that it would have come into play. So it's reasonable that they're seeing an outbreak. Like that can occur. It doesn't necessarily mean that the vaccination campaign isn't working. And when you look at the infections, you do see that a large number of the infections in the country are in people that haven't been vaccinated, in tourists that have come into the country, or in people that only have 1 dose of the vaccine. So, of course, again, that would make sense. But the thing that they are seeing is that there are infections of people that have been vaccinated. So that is occurring here. But the sort of other really important point is that, which vaccine is primarily being used. And in the US, in Canada, you're talking all about vaccines like Pfizer and Moderna. And those are vaccines that have extremely high efficacy. They're really good at preventing people from getting COVID disease. Now, some of the other vaccines, we talk about AstraZeneca. AstraZeneca has a lower efficacy, but then they have a lot of other vaccines from other countries. China has multiple different vaccines. We have the Sputnik vaccine, but in the island, it's mainly been, I'm not 100% sure exactly which vaccine, but I'm pretty sure it's one of the Chinese vaccines that
Yeah,
has,
I'm pretty sure it is one of the Chinese ones. I
I
can't
think
remember
it's
which one it is.
Sinopharm, or it's Sinopharm or Sinovac. And this is a vaccine that has an efficacy rate that is just over 50%.
Mm.
And the WHO early on set a threshold for efficacy of saying, like, in order for the vaccine to be approved, in order for people to use it, we need to see that there's an efficacy of at least 50%. And so they just met that threshold. But that means that this vaccine is not nearly as good as some of the others at stopping COVID illness. Now, it's still quite good at preventing severe COVID illness. So, in the country, they're not seeing this massive overrun of hospitals. They're not seeing this huge spike in fatalities that you might think of with a COVID outbreak. And part of that is probably due to the protective effect of the vaccine. It doesn't mean that people aren't getting the disease. It just means that when they get it, they're protected from some of the most severe effects. So you have multiple different components at play. You have part of the population that hasn't been vaccinated. You have part that's only been partially vaccinated. And then you have a vaccine that isn't quite as efficacious. So all of that combined with the fact that we now have variants that are starting to evade the immune system, whether that's the South African variant, the Brazilian variant, the Indian variant. So you combine that all together, and we're getting a fairly big outbreak. And so it's an interesting case in point, but it doesn't mean that the vaccines won't protect a country or won't protect a community from COVID illness. It just means it's really complicated, and there are lots of components that factor in here.
One thing that came to mind, is it like, I agree. I haven't heard anything yet about hospitals getting overrun or anything of that sort. But is it perhaps too soon to look at the death rates? Usually that follows up a couple weeks after or so. It seems that the infection spike is still pretty recent, if I'm not mistaken.
So yes, we always see that where you see the fatality rate that rises, maybe 2 weeks or so after you see that spike in cases. And so it is very possible that you're going to see some of that, but there's still it's 60% of the population has been vaccinated. And so that is going to have a significant impact on that severe illness, on that really on hospitalization and on fatalities. And so we don't know exactly what's going to happen in a couple weeks. We could potentially see that rise in fatalities, but I don't think that's what's going to happen. We might see some of that with the people that haven't been vaccinated, but specifically in that vaccinated population, I don't think you're going to see that. And I think that is going to attenuate this impact on the health infrastructure and on the fatality rates that we're seeing there.
Okay. And you mentioned the herd immunity threshold. Now, like, this has been, you mentioned it's sort of arbitrary, and it's been tossed around for quite a while for for different means. How did they come across that specific number? I'm sure they didn't just fully pull it out of the air. Maybe they did. Like, where does that 70% number come from?
Yeah, so this 70% number is a calculation that is based on how efficacious the vaccine is, or protective immunity, how, if you had been infected before, takes into account the R number, the R naught of the virus, which is something that we talked a lot about early on in the pandemic, but is something that has sort of fallen off the radar quite a bit. And this is basically a measure of, how likely, if one person gets infected with the virus, how likely are they to spread it on to X number of people? So the higher the R naught is, that means that one person infects, two or four or eight or 30 different people. So the higher that value is, effectively, the more transmissible the virus is. And so if you have an R naught that is, very low, then it's a little bit easier to contain. And part of the problem is that this R naught changes with the different variants. And of course, R naught is sort of where you start with how transmissible the virus is, but it's all then taken into context of what the local environment is, what the restrictions are, what the different actions are. So it is a dynamic process. But basically what this means is that it's a calculation that takes into account multiple different variables that aren't just what vaccine you've used, but also, what virus are you seeing? So, and importantly, it's an estimate. And, we've seen a lot of times that you do estimates with almost anything in terms of COVID, and it's a helpful starting point, but you can't rely on that for the way things are going to go. I mean, we've seen that in, the US and Canada and prediction of case numbers and fatality rates and things like that. It's a useful tool, but you have to remember that it's just a tool and just an estimate, and not necessarily an indicator that if you get to that level that came from the estimate, that all of a sudden you are going to see something occur, in nature. You might, but you also might not, because it's just an estimate.
Gotcha. Now I'm going to jump gears here. We talked before about the different vaccines, and we went over the point of there's differences, and they're not perfect, but pretty much any vaccine is better than no vaccine, taking into account the contrary. But so what's happened recently in Canada, and I'm not sure if this is happening a lot elsewhere, like and before we discussed, and I'm sure a lot of the audience will know, that there's been sort of a dance around with AstraZeneca and Johnson and Johnson, countries taking a long time to bring them in to a component of their overall vaccine distribution, or pausing them for a while. And now the trend has been in Canada, and I'm not sure how it started. I know before a lot of the provinces paused AstraZeneca, that Dr. David Fissman and Dr. Andrew Morris came out and said, well, with how well Pfizer is, and both mRNA, Pfizer and Moderna, how well they are, with this blood clot thing, well, perhaps we should I think it's about time that we got rid of AstraZeneca, which, personally I thought was unwise, because still, because from my perspective, there's two issues there from my perspective, whether, as much my perspective, it might completely lack merit. There's the one issue of, it's still a chunk of the vaccine supply that then gets taken out. And the second issue is that if some people out there would prefer to take the viral vector vaccines and say, for whatever reason, I don't really want to have the mRNA vaccine, I'd rather have this one. Well, then you're not giving people choice, and you might have, I'm not sure if this would maybe even be the case, that people who might think this way, it might be infinitesimal, but might have then some hesitancy and maybe skip out on the vaccine. And considering how low this blood clot issue is, and maybe there's something new on that you can comment on, it just seemed to me really unwise. And then following that, I'm not sure if this is the reason that some of these scientists and physicians made this recommendation as to why the provinces started backing away from AstraZeneca, and if this is occurring anywhere else. But does it seem unwise to you at this point to for places like most of the, I think it's just a couple provinces who haven't, stepping away from AstraZeneca at this point?
So it's a really complicated problem because all things being equal, we look at the data from the mRNA vaccines, and the mRNA vaccines have a higher efficacy rate. So that's great news. And then you look at these blood clotting disorders that people are understandably very concerned about, and you're looking at that with Johnson & Johnson and with the AstraZeneca vaccine, and it's an extremely low rate, so this is still a very rare event. But so you're saying, well, Pfizer and Moderna, there's a higher efficacy and a lower risk of this blood clotting disorder. So all things being equal, well, why would you not go with that? But the issue is that, of course, all things are not equal. Because yes, if we had plenty of supplies and plenty of freezers and plenty of ultra low temperature storage for the vaccines, and we could, get enough vaccines for everybody in the world tomorrow for Pfizer or Moderna, great. That's an easy solution. And I'd say, yeah, go ahead, do that. Don't use AstraZeneca for it. But of course, that's not possible. That's not the reality. And right now, in many countries in the world, vaccines availability is extremely limited. So some countries, the US is doing better than many. Some countries have been doing even better. And there are many areas in the US right now where anybody can just sort of walk up and go get a vaccine on the spot. And that's great. And sometimes you can even choose, which vaccine you would like to get. That's wonderful, but that is not the typical situation in the rest of the world. Many, many countries have very low rates, very low availability, and are at a course that it's going to be many months, if not potentially years, before they are able to vaccinate their populations. And those are countries that have access to the vaccine, that can afford the vaccine, and are still struggling with that distribution and having enough supply for everybody. You then go further out in the world, and you've got many countries that can't afford the vaccines or that don't have access to them, can't pay the royalties on the patents, can't do this in order to actually get those vaccines. And then you have a really big problem because, of course, it's so easy to focus on your local environment, your local community, or your local country and say, great, we're doing wonderful in terms of vaccination. And, you might be, and that can help a lot right now. But the virus is still going to exist in the world. So say tomorrow the US got to 100% vaccination. Wouldn't happen, but it would be great. That doesn't mean that the US is no longer at risk. Because what you have to remember is that the virus is, of course, still evolving because it's still spreading throughout the rest of the world. And what we've seen time and time again is that the more the virus spreads, the more chances it has of mutating, of forming a new variant. And what we're seeing is more and more variants that have started to evade the vaccine protected immunity. And so if you just focus only on your country and ignore the rest of the world, well, then you have a really big problem, because then, first of all, that's dramatically inequitable, and you are putting so many people's health and lives at risk. But you're also running the risk, even if you're just viewing it self-centeredly, you are at a huge risk because the virus is going to continue to evolve in other countries. And that will then, of course, continue to spread around the world. And eventually you might get to a point where, yeah, you did wonderful in terms of the vaccine rollout initially. Well, but now you have a new variant and now you got to start over. So that's a real possibility. So we need to be looking, yes, definitely looking locally, what we can do right here, right now in our area. But we need to be thinking about vaccines in terms of vaccine equity, in terms of vaccine distribution, in terms of things like patent waivers for the technology and transfer technology to allow the mRNA vaccines or other vaccines to be made in other countries, how we're going to help get those vaccines out to other countries. And this is where having many different vaccines is incredibly important. Because, if you're in a country that doesn't have good vaccine availability in general, but, maybe they have a campaign, they're affording it, until fairly recently, I would have said that's true for Canada, although they seem to have changed the pace a little bit, but still have some problems. But many countries in Europe, too, it's not a matter of being able to afford the vaccines. It's a matter of how they're distributing, the availability, the time span. And so in those contexts, if you took AstraZeneca out of that equation, you would have a significant slowdown of the vaccine distribution. And it would take a very long time for people to be able to get vaccinated. And it's important to remember that, we're not talking about here AstraZeneca being a bad vaccine by any stretch. It is a very good vaccine at preventing critical COVID illness. Yeah, Pfizer and Moderna are slightly better, but if we had only had AstraZeneca, everybody would be quite happy right now. This would still be a wonderful vaccine. And yes, it does have some side effects, but they are very rare. And, cough medicine has side effects. Painkillers have side effects. Side effects happen. It's something to be aware of. It's something for medical professionals to monitor. It's something that we need to understand why that occurs so that hopefully we can prevent it. But the risks of blood clot disorders from the AstraZeneca vaccine compared to the same risks of blood clot disorders from the COVID disease itself doesn't even compare. And that's just on blood clotting. So it's that sort of comparison. So this is still a good vaccine. And it's a vaccine that can be stored at a much warmer temperature, which makes it far easier to distribute. It's a much cheaper vaccine. And it's also just fairly widely available in many areas right now. So the combination of all of that means that this is an integral component to many vaccine strategies in, say, European countries, but it's also a really important component of the international vaccine distribution. And so if we turn that away, if we say, no, we shouldn't use AstraZeneca, this is going to have very significant impacts for our global vaccine distribution and global vaccination. And given the impact that COVID's having, we can't afford to wait that. People's health and lives can't afford to wait on that. I mean, this is one of the reasons there are so many organizations right now that are strongly promoting global vaccine equity and what we need to do. Patent waivers, global distribution.
I'm going to pause you there, Jeremy. And yeah, you're tying in two good things here. The international vaccine distribution. That's really the big main topic that I wanted to touch on with you today. After a couple other things, I think we have quite a lot to dive into there. But and then on that too, the question that's coming to mind then, beyond how it affects a country within their borders, if they're denying the use of X vaccine, how does that specifically affect, like, we'll use this specific case when Canada says, no, we don't want to use AstraZeneca anymore for, it's not really clear what their reasoning is. How does that then directly affect the rest of the global vaccine distribution if one country is denying one vaccine themselves?
Yeah, there are multiple components that you need to sort of factor in there, because on one hand, it's just purely the psychological side of it. So, if you're going in tomorrow to go get a vaccine and you are told that, okay, what we have available is AstraZeneca, but you read yesterday that Canada had said, no, we're not going to use AstraZeneca, maybe you're not going to go in and get the vaccine. Maybe you're going to really second guess that choice. So there's this impact on vaccine confidence that comes from countries saying, no, we're not going to use it. but it also has, a lot of other effects because, when we're talking about vaccine equity, well, you don't want to get in a situation where we're saying, okay, well, we're going to give you the bad vaccines. We're gonna, okay, well, we don't really want to use that anyway, so we'll send it to the areas that don't have any other options. I mean, people were
Uh,
worried about that for a long time for just cause, but this isn't. We don't want to be sending the products that we don't want to use to other countries that need them and don't have any other options. That's not an ethical way to help combat global vaccine inequity.
yeah, that's a great point, Jeremy. Just not even any logistic specifics, but just how you're presenting yourself, and it would also seem kind of obnoxious too. I'd think for the rest of the world, you look at somewhere like Canada, and I think it was a lot of really bad logistic issues on our front, and we don't really have a lot of the wisest people in Ottawa right now, unfortunately, during this crisis. But the rollout has been bad here for logistic reasons. But now once that's gotten taken care of, we have all that we want, and now it's sort of we're in this position of pomposity where it's like, oh, we don't need AstraZeneca anymore. And that's a good point. It's sort of a really bad message to send to the rest of the world, atop of everything else.
It is. It's been something that within the U.S. has even been a struggle because so there is there's been a lot of discussion about the Johnson and Johnson vaccine. And because it had that lower efficacy, even before we started getting into the whole blood clotting disorders, it's a lower efficacy. But Johnson and Johnson vaccine had the real, very strong use case of being a vaccine that you could give with a single dose. So if you had areas where there was very high transmission, you had a large population that you wanted to really get as many people vaccinated as fast as possible, then having, say, a convention center as a vaccine clinic where you're vaccinating as many people as you can with one dose and getting them really protected as fast as possible makes a lot of sense. But the problem is that a lot of those areas tended to be in urban areas and tended to be in areas that were, of course, having the highest rates of COVID and suffering the most under COVID. But we've known for a long time that COVID really plays into existing systemic inequities. And so you get areas that are already disadvantaged, and that's where you see highest COVID cases. That's where you see these highest impacts of COVID because it's building on all of the inequities that already exist in the system. And so if you're saying, look, from an epidemiological standpoint, you want to go into those areas where they desperately need the vaccine and get them vaccinated as quickly as possible. So a single dose works perfectly for that. But then if you think about it in the other context, you're saying, well, great, we're going to go into this area that has been disadvantaged and suffering from inequities for many years, and we're going to give them the second string vaccine. So of course, that's not why it was done. But you have this real issue of sort of messaging in which vaccines are being used, how and why. And it gets very complicated very fast.
Indeed. Um, I got a couple. I think we should get on to the. Well, we're going to on the issues of overall vaccine distribution. But I got a couple other questions to ask you before we totally jump into that. Now, you sort of mentioned before with the mRNA vaccines about how they have to be kept so cold and all of that. One thing that's crossed my mind, has there ever been any issue that anybody's observed of them being mishandled, and then as a result, they essentially become a placebo, or is there just really no way that they could keep track of that? And that's something that we might come across later, or is really the handling of it going so well that that's essentially just a non-issue?
Overall, from what we hear about these days, the handling of that is actually going quite well. Earlier on, you definitely heard about some issues of mishandling of the vaccine and temperature. Especially for Pfizer, that required that ultra low temperature storage. Although, that's been restudied, and it looks like they might actually be able to work at a slightly warmer temperature, which makes it very helpful. But yeah, you were getting these situations where the a vaccine dose was a multi-dose vial was perhaps thawed when it shouldn't have been, or wasn't frozen appropriately. You had a couple of those, but it was sort of it seemed very much like this was occurring during that sort of teething period of rolling out the different vaccine campaigns, figuring out how those logistics are working, and the different vaccine distribution sites just sort of working on their own process. And even though the ultra low temperature storage had a little bit larger of an impact, it wasn't something that you wouldn't see with other types of distributions, where you sort of iron out those little details at the beginning. So it didn't ever seem like it was something where people were getting a vaccine that had been stored inappropriately and so were risking getting a placebo. It sounded more like some doses of some vaccines had to be discarded because they weren't thawed or stored as appropriate.
Okay. Now there's as we mentioned, here they're wanting to step away from AZ, and I'm sure this will happen in a lot of other places. Is there any issue with mixing and matching that they know of, or is it just in principle there shouldn't be any problem? What are your thoughts on that?
I'd love to be able to answer that question. It's a great one. It's one on so many people's minds, and yeah, we just don't know yet, because in theory, it should work fine. In theory, mixing and matching the vaccines might even work better. We just don't know. And so the whole point of the clinical trials of studying these vaccines are that you have a very specific vaccine given at a very specific dose at a very specific time, and then you're monitoring what happens in terms of side effects and in terms of how well the vaccine works. And so at the end of those clinical trials, you get very good data that says, yes, this protocol for this vaccine works this well. And that's what we then use. Now, once you start to say, okay, well, we're going to take part of this vaccine, part of this vaccine, then all of a sudden you're sort of going back in terms of that evaluation stage, because just because each vaccine worked really well and safely independently doesn't mean that they're going to do the same thing if they're combined. And if they are combined, which one you start with, how long between the vaccines, and how much you're given will all play a role. So we need to evaluate all of those parameters in more clinical trials. And those clinical trials are ongoing because people really want to know this. Part of the reason for that is that the mRNA technology vaccines can be manufactured in a new version to address, say, a variant much faster. And so there's a real case for saying, okay, maybe somebody got fully vaccinated with AstraZeneca, but 6 months to a year down the line, there's a new variant. We need a new variant vaccine, and that's quicker and easier to do with AstraZeneca, with one of the mRNAs than AstraZeneca. And so we look to see how that responds. So it could also be the scenario where, okay, you get one dose of Pfizer and one dose of Sinopharm, and the combination of those two gives you a 99% efficacy and no side effects. Who knows? It could be the opposite. But the issue is that if before you do those clinical trials, you're just guessing. And you can't just guess on this, because we need to know that the vaccines work and that they're safe. And so this is why we slowly do clinical trials with more and more people, always evaluating, are they safe and are they working well? I'm optimistic that the combination approach will work, but we just need to wait for the data.
Right. Well, probably would be just best if I think they would just stick to, if you started with AZ or Pfizer, take that again. But that's obviously becoming an issue. Anyway, uh, one thing I'm coming across a lot more too is people are. I'm hearing more and more. Some people are having concerns with the mRNA vaccines just because they're so novel, and like they did the clinical trials, and they, from what I've observed, everything went really well. But they're just concerns that this is a new thing, and the trials were short because of the absolute necessity of getting these vaccines out for obvious reasons. What would you say to anybody who's squeamish about the mRNA vaccines and has any concerns and general hesitancy in that regard to Pfizer and Moderna?
Yeah, it's something that we talk about a lot because I mean everybody's got concerns about vaccines. This is something you're putting into your body, so you know we all have concerns about that, and this is where I come back to that clinical trial data because that's what this is designed to do. That's what it's designed to tell you, is to say, how well do they work and how safe are they? So when I say, yeah, I am recommending that, great, if you have an opportunity to get, a Moderna vaccine, or you have an opportunity to go get your Pfizer shot, like, yeah, go, great, do that. This isn't just a feeling. This isn't me coming at that and saying that I'm very pro vaccine and I think that they're helpful and important. This is based on the data. This is because I sat down, looked at what the data said from the clinical trials, and evaluated what the different side effects are, what the risks of those side effects are, how well the vaccine works at protecting you from COVID and severe COVID disease, but also what the risks of severe COVID disease are, and the risks of getting long COVID, even if you have a mild case of COVID. And so it's a matter of saying, look, ideally, we would never have to use the vaccines. We would never have to have a COVID vaccine. We'd just be able to get rid of the virus and nobody would have the vaccine, but nobody would get COVID. That would be great. I would much rather not have the vaccine. But the point is that COVID exists, and the risks of getting COVID are so much greater than the risks that come from the vaccines. And that is the balance that I'm encouraging people to look at and think about, is that, ideally we wouldn't have either risk. But we have that risk of COVID. We have COVID in the communities. There is a risk of severe illness. There's a risk of fatalities. There's a risk of spreading it to people that you love and care about. And there is a risk of getting COVID, thinking that you're fine, and developing a long-term chronic illness of long COVID that can profoundly affect your life. These are not risks that I'm willing to take, especially compared to a vaccine that has incredibly low risks of side effects, and things like painkillers, or cough medicine, or antihistamines, or so many other drugs that we buy over the counter that we don't necessarily even think about have more side effects than some of
Yeah.
these vaccines.
Yeah, definitely. Like, how many people's stomachs have gone to shit from too much ibuprofen or something?
Exactly, and of course, I'm not saying like, oh, don't go use any histamines or painkillers or anything like that. Like, it's not that they have such high side effects. It's just that we're accustomed to the fact that, like you said, if you take too much of ibuprofen, it can cause some stomach disorders. That we're sort of accustomed to that, but this is something new. And that sort of gets back to your question of the sort of newness of this, of, well, this is so new, so isn't that a concern? Why should we trust that? And I guess the sort of two answers to that is that, first of all, yes, this is a new vaccine on a new technology, But it's not like they just invented this mRNA vaccine technology for the pandemic. This has been in development for decades. They've been working on this for a very long time. Yeah, this is the first one that we're using. This is the first one that has made it that far. But this isn't a brand new technology that we're just jumping into without knowing what's going on. And the other aspect is that, again, this is why we have those clinical trials, so that we can say, even if it's something new, that doesn't necessarily mean that it's going to work any differently or it's going to be any more dangerous. In fact, the mRNA technology actually looks to be better than a lot of other vaccine technologies, both in terms of how effective it is, as well as how safe it is. So, I mean, this is really good news. And of course, the clinical trials aren't over. We have that phase 3 data, but we continue to evaluate the safety and the efficacy of these vaccines for many years to come. So, of course, we're constantly getting more data. And if we ever see any signs that, of course, things are working differently than we've seen before, then we'll be able to respond quickly and adapt. But we're continuing to evaluate them and will for a long time.
Now, on that, yeah, I agree with you. And the risk with yourself, your friends, as you mentioned as well too. There's the collective risk. It's like that this virus is getting grumpier. So you have to ensure that we can stop this spread by all means that we have, because that's of course this unknown that we have as well going into the future, and
Mhm.
and the trend there is less than swell. So then a negative looking forward, and in a positive. Let's start with the positive, and then touch on a hypothetical negative, if there's any way you can comment on that. Maybe it's just you two out there that it could be anything. So like you mentioned the mRNA technology and how it's been working. As it's crossed my mind, a positive scenario that I've thought about is, could this just, if there's no real side effects from this and we're able to update it as fast as you mentioned, that seems to be the case, could this be just an extreme breakthrough in modern medicine with the mRNA? And then also, if it's at all possible, and entertain like what are some unpleasant possibilities that could accrue from negative side effects long term, that you might not find about for another year or two or something from the vaccines, which seems to be the general idea I'm getting from people on mRNA concerns.
So it really is a game-changing technology, just because it can be adapted so fast to a variant of the virus, or a new virus, or a new disease. It can be adapted incredibly fast, and the manufacturing can be scaled up very fast. So this is an incredibly adaptive platform that could allow you to develop and change vaccines very quickly and much more affordably than was possible before. So that has really significant implications. So, we talk about the flu vaccine. You need the flu vaccine every year, but if you're doing that with mRNA technology, then perhaps that gets faster and also cheaper to do. It's entirely possible. It's entirely possible that this could provide a route that, things, what we call neglected tropical diseases that, affect countries that don't have the vaccine technology platforms and don't have the resources to be able to develop vaccines for these diseases, that maybe we could actually be much more able to make these new kind of vaccines that are useful not just in, say, Canada or the US or the UK, but more globally. So there are a lot of opportunities there. But of course, there's still a really significant issue, which is that you still need the clinical trials for these. And so even if you adapt the vaccine manufacturing technology, which is great, that significantly helps, and it really shortens that time frame in which it takes to develop this. but clinical trials still take a long time. And of course, clinical trials take a longer time if you have a disease that doesn't have a lot of cases every year. So with COVID, you're looking to say how the vaccine performs. And if you have a lot of COVID in the country, you're going to get that data really quickly.
Mm.
But if you're doing that same sort of clinical trial and you only have a case here and a case there, then it takes a lot longer to collect the data that you need. And so that is always going to be a really time consuming step that's going to slow down this whole process. Now, maybe someday we'll figure out a way that we can shorten that process. But of course, we can't cut corners on vaccine safety and ensuring that it works. So this is helpful. It means that it's more affordable and faster to make new vaccines, but it doesn't mean that the whole process is necessarily more affordable or faster. It shortens it. It definitely shortens it, but it's still involved and it's still costly. So yeah, it's a game-changing technology, but it's not going to completely rewrite it such that anybody can go say, oh, here's a brand new disease. It only affects this one community. I'll go make a new vaccine and we'll have that in people's arms in a couple weeks and it won't cost too much. We're nowhere near at a level where we could say that, but it does help the whole process dramatically.
Okay. Gotcha. Thanks, Jeremy. Now, let's jump gears back to what we were touching on before, and I assume we'll spend the rest of this conversation with, and that's the international vaccine rollout. There's a lot to touch on, so let's start with how you see things going at present rates, and then we can touch on what could be done to change that. From this point in time, the way things are going, it seems like it's going to take over a year to get it all rolled out, and then the virus can spread to all sorts of different places and keep mutating, and who knows what can happen as a result of that. How do you see it going so far?
Globally, very poorly.
Yeah.
There are some countries, individual countries, that have done or are doing very well. Some countries where the pace is picking up a little bit. But, this has been the vaccine and the distribution of the vaccine, it has been prioritized with doses to wealthier countries that have signed contracts with vaccine manufacturers that can afford to pay that fee for the vaccines, and often countries that were involved in the vaccine manufacturing. This is where the majority of the doses have gone so far. And this is a big problem because even some of those countries have been struggling with their vaccine rollout. Even some of those countries are still looking at, potentially years before they've vaccinated, say 70% of the population. So, that's not going particularly well in a lot of areas. But when you look globally, there are many countries that have, very little, if any, vaccine. And so that's and they don't have this outlook that is say, okay, well, we're looking at 6 to 12 months before we vaccinate it. They're looking at, well, are we going to be able to vaccinate? And it's not a matter of how many months. It's a matter of is this going to be possible? And if so, potentially how many years is that going to take? It's a real problem. And we're also having that added part where, some countries are sort of, doing, I think what's called sort of vaccine diplomacy, where it's sort of using the distribution of vaccines in certain countries as a political tool. And so that further complicates the scenario, because on one hand, that's great. Getting those vaccines out almost any way you can is really important. But on the other hand, where are they going? How are they being used? And under what circumstances is this actually occurring? What we need is a real system that actually gets those vaccines to the countries that need them to countries around the world so that all countries can have access to the vaccines and start vaccinating. And that's just not happening right now.
Oh, what are some instances of it being used as a political tool, as you mentioned?
This gets well out of an area of expertise that I feel qualified to comment on the political implications or the political sides of that. This would just be things that I've read, but no, this is. I'll stick to something that I can have an educated comment on, because I've these are things that I've heard that are occurring, but not not in my area of expertise enough to actually be able to weigh in on what is actually going on and why.
Okay. Yeah, maybe we can come back to that one in another day. Like, is there like anything, any examples that you've kind of heard about?
You, yeah, I mean, so you think about it, the vaccines are really sort of, this is a really valuable, if you will, it's a really valuable
It's a commodity. Yeah.
and especially in areas where vaccines are not available. So what you can sort of, if you're not viewing vaccine distribution in a sort of humanitarian standpoint, then you have this issue of, well, okay, so it's sort of like a commodity. And so, there have been times where, we've heard these stories about, vaccines being brought to, in terms of like climbing trips on Mount Everest, as, this is maybe a little bit too far, but almost as bribes or a way to sort of smooth over the process. But of course,
Oh,
there have been outbreaks, with some of the climbing teams. There have been some outbreaks in some of the expeditions, and so you do have this dynamics. And then of course, countries can use the vaccines. I mean, if you're doing this big push for vaccines, and this is the generosity of some specific country, then that then used for currying political favor or for new trade contracts, or vaccines are often used as political bargaining tools. And you can do that in a lot of different ways. And it's happening. It's happening on small scales. It's happening on large scales. But this is a in that context, vaccines are incredibly valuable commodity that you are bringing to a country that really doesn't have access to that, and that is dramatically furthering the inequity that is sort of driving so much of this COVID transmission in so many different areas. So you want to be, you can't approach global vaccine equity from a lens of commerce or trade or political favors.
right. Interesting. And yeah, I won't be surprised if we see, if this becomes more of an issue as time goes on, that the three big powers that be, as far as vaccines are concerned, start to use it as a tool. But now you mentioned that we need a new system. So let's go over specifically what that would entail.
Right. So, we definitely need a new system. And, that's, first of all, of course, not a simple or trivial thing to be able to do or to even contemplate doing, especially given the fact that the global supply of vaccines is very limited right now. So what we're talking about are multiple different factors at play. So, one thing that's being talked about is that, a World Trade Organization waiver campaign. So this is a campaign to waive the patents on the vaccines, to allow the vaccines to be used globally at a much more affordable rate that can actually help to facilitate this global vaccine distribution. So that's one really important thing. And in the US, I'm very pleased to see that Biden recently changed the U.S. policy and came out in support of the waiver campaign, which is a really significant step. And as in Canada, Canada is still on the fence. They haven't committed one way or the other to saying whether or not they're going to come out for the waiver campaign or not. But one of the biggest holding blocks right now in terms of this waiver campaign, because there are a lot of countries around the world that are very strong supporters of the idea of waiving patents for the vaccines, are most countries in Europe, because the vast majority of Europe right now has come out against the waiver campaign. And so, countries from the UK Brussels has recently actually come out in support of it, but the Netherlands and Germany is a really big country that is strongly coming out saying, no, we don't support this waiver campaign. And so together, this is a really strong bloc of countries that is opposing waiving the patents for the vaccines. And because of this is blocked. Now, coming up in the beginning of June, the 8th and 9th in June, there's going to be a WTO meeting where they're actually going to be discussing the waiver campaign. So there's a lot of movement right now to try and gain awareness to emphasize how important this step is for global vaccine equity. So that is in progress. Now, so that's one side. The patents are a really important thing because this affects the whole costing and the ability of other organizations to make these vaccines. But just having that removed, that's not enough. That doesn't magically make vaccines appear. So then you have that other side of, okay, so what do you need to do next? And one of those answers is this idea that the World Health Organization has been promoting as part of COVAX, which is this mRNA vaccine technology transfer hub. This idea of, can you actually develop the manufacturing technology, expertise, capacity in other countries to allow the countries themselves to make vaccines, or even regions to make their own vaccines, that coupled with having the vaccine patent waiver together may allow for sort of much more regional developed vaccine manufacturing. And now that's still going to take time to do, but with that technology transfer and with the patent waiver, that goes a long way in saying, instead of just the vaccine coming from, say, the US or coming from China or coming from Russia, we actually have a much more distributed network of vaccine manufacturing that will greatly help the distribution. And of course, the final thing is, of course, that, this needs money. This needs money and this needs vaccines. And so, looking at how countries can utilize their vaccine distribution, utilize their supply of vaccines, how countries can donate vaccines, can fund programs like COVAX that can help globally either get vaccines that already exist into countries that need them, or get the funding to start these, technology transfer hubs and really get that manufacturing up and running is really critical.
Now, what would be the case against the patent waivers? Like, is there any concern that if there is no patent protection, that anybody's making them, and then you might have, like, as with some concern with generic drugs, that you get bad manufacturing, making bad products, and then issues there? Or is there, what are, or on top of that, what are some other points to be made for the case of holding on to the patents?
So one of the arguments that's being used against it is saying that this is going to impact, impact vaccine manufacturing, make vaccine manufacturing less profitable, it's going to stifle competition, that it's going to have an overall detrimental impact. But on one hand, there is an argument to be made on that side, but on the other hand, this is a pandemic. This is not a company that is making a product that then they are trying to sell. And to think of a vaccine as a product, and to me, this is one of the critical distinctions: is that if you're viewing a vaccine as a product, well, then competition and business development and marketing and even just diplomacy issues and trade deals, then that really comes into play. But this is a pandemic. This is not just a product. This is a critical, essential, life-saving medicine. This is something that needs to transcend that idea that a vaccine is a product. And we need to look beyond that, because otherwise we are all going to be at risk.
Hmm. Yeah, because it's not even let's say you just throw the humanitarian concerns down the shitter. Like it's really just the antithesis of self-interest, because as we've mentioned, they can just keep spreading, and who knows how deep the rabbit hole is going to go. Now, on the I guess now you sort of touched on like there's the hurdle of actually being able to get more vaccines out there by not having it constrained with the patents. Like, what are some more of the broad scale logistic concerns that that would need to be taken into consideration, and to watch for, if this does occur and we're able to start getting more vaccines out there? What's being done there, and or what else could be done?
No, that's yeah. It's a really important point, because this, so much of this is great in theory, but then when you actually are trying to put it into practice, the logistical barriers of this are immense. And okay, so that is everything from saying, okay, what temperature do the vaccines need to be stored at? And if you're then distributing the vaccines across the country, do you have that cold chain capacity? Can you maintain that vaccine at that temperature until you get to that distribution point? And that also affects, if you're doing this sort of, technology transfer hub model, well, you have to look at the subsequent distribution, because maybe you need much more local sites for the manufacturing than you would need otherwise. Or maybe you have a really good distribution network. You do have capacity for cold storage, in which case you might have more capabilities there. Also, the vaccines all differ in that cold storage conditions. So how each one works is going to be slightly different. But all of this infrastructure, from getting the manufacturing capabilities, just in terms of instrumentation, to different countries, to setting up that site where they can actually manufacture, store, package the vaccines, that's not a small technological and logistical hurdle. But then you need the expertise. So you need the logistics to make sure that there is that local expertise to be able to run that facility. Then you need to have that logistical capacity of the distribution network. And we've seen in many countries dramatic failings in distribution. And I mean, I'm not even in countries that really should have systems in place that really don't, or sort of fail at that distribution side. So that's not trivial either. And then, of course, you need that messaging side, because it doesn't do you any good to get the vaccines out to your local community and then have the community either not know or not care. So there's massive logistical hurdles. And a lot of people are working on this extensively, trying to figure out how you do that. But in the best case scenario, you have an adaptable model. You work with what is already there. You don't want to try and recreate something and have to build something from scratch. So, you work with the closest local manufacturing capacities that you have that might be able to be adapted with this technology. You work with the local research expertise to develop the training. You work with the local distribution networks for whatever exists in that region. So the more that you can sort of work at a local level, learn from the local community, work with the structures that they already have in place, the easier this is going to be because the less you're going to have to develop. But that means you need that adaptable context and framework, and also that sort of listening approach of not coming into an area and saying, this is how we're going to do it, but listening and talking to people and understanding, what resources are there, how do things work in that region, and then have an adaptable model that works in that context.
Okay, could you give a specific example on that, just to highlight that a bit more? What that might look like going into a certain place, and then trying to make something adapt accordingly.
Well, yeah, I mean, it's so sort of as I mean, first of all, this is again way further off field from my specific area of expertise. But it's from my perspective. There's just, if you go into different areas, there are systems in place because goods and people are constantly moving between different areas. Things are being manufactured. There are a lot of systems in place already. And so the more that you can work and adapt with that, and this can be anything. I mean, certain areas, okay, so maybe there isn't good distribution networks by road. So maybe you have a system where you're in some areas you're distributing vaccine by boat. Maybe in a certain area they have really good manufacturing capacity, but they don't have the strength of research capacity. And so you help bring in that outside research expertise, but then you work with the local manufacturing. Or maybe you have an area that has really good research but doesn't have that same level of manufacturing expertise, in which case you bring that expertise in. So it's there's not a, I mean, again, I'm not the one to be saying how this should actually be done, but there's not a hard and fast rule. It's just, it's a matter of saying, look, we know that you need to make the vaccines. We know you need to be able to make the vaccines. You need to package them. You need to store them. You need to get them to the people, and then you need to talk to the people about what's happening and make sure that the people actually want that. And so in all of that, the more that you can be working with the local context, the easier it's going to be doing that. So, we look at, talking to people about the vaccines and vaccine confidence. And if you just have a broad messaging campaign where you have one message and you send it out to every community, that helps to some extent. But it doesn't help nearly as much as if you go into a local community and say, okay, so tell me about your community. Tell me about what your concerns are. Why are you concerned? What do you hear about COVID? What do you hear about the vaccines? And let's actually talk about what the situation is by, listening at a community level and then sort of responding with that expertise, responding with those resources. Then you can develop a really positive and really strong partnership that helps people be a lot more confident in the vaccines and a lot more engaged in the process.
Okay. Now I'm going to jump back a bit. Now, this for sure touches on the humanitarian crux of the issue, but it might also generally tie into overall interest of the whole world. I'm not too sure, but so as an alternative, or maybe more so a counterfactual, at the beginning of when the vaccines started to trickle out, should have there been a global initiative, even with patents in place and the initial vaccines, to try to start spreading the vaccines all throughout the world, to and not so much where so much are just going to specific places, and it's sort of a situation of look after yourself and then figure everything else out later, where try to have everybody coordinated and try to have a sort of an internationally coordinated vaccine rollout that way, because there's already it's not like the first world countries aren't spending a whole bunch of money every year on aid. So it doesn't seem so much a monetary issue. And as we mentioned, with the vaccine or the virus just spreading more and more and mutating, there seems to be a lack of self-concern there. Should there have been just a different initiative and trying to spread the vaccine around, and what might how might that work?
So this is not new. This idea of saying, all these things that we've just been talking about, none of these are particularly new ideas, nor is any of it particularly a novel idea. It doesn't really need to be. These are things that people have been thinking about and talking about and pushing for from the beginning. This is something that people have been aware of, and things like COVAX have been going on for a very long time. So this is not new. It's just that it hasn't worked. That it hasn't, that traction, that engagement, and whether that's individual countries started saying, no, we're prioritizing our vaccines first, and then we'll think about internationally, or whether that's vaccine manufacturers that are focused on patents, and or whether it's there are a lot of different elements in play, but this has been promoted, talked about, tried for many months now, and we're still fighting it. We're getting more traction. There has been more vaccines that have been distributed internationally. There have been, more countries that have come out in support of the waiver campaign. There is progress, but there hasn't been so much progress that it's actually resulted in good vaccine distribution. I mean, through COVAX, and the World Health Organization, they have gotten supplies of vaccines that they have been able to distribute, but it's been low amounts, because it does tend to be. It's not that countries don't do aid. It's that the priority is looking to the country first, and of course budgets are often being cut right now because the pandemic has had such a significant financial toll. So it's been a constant struggle, and unfortunately, I think probably will be a constant struggle for quite a while.
It's hard to take an optimistic look at it all. It, are there any other sorts of things that should be addressed with the international vaccine rollout to try to make this whole situation better?
Well, I mean, I guess one thing that's important, you said it's hard to keep an optimistic outlook on this, and yeah, it's absolutely true that it is. But I guess one thing to keep in mind that is also sort of a little bit more optimistic of a viewpoint is that you know, we're talking right now about Pfizer and Moderna and AstraZeneca and Johnson and Johnson, and then a little bit talking about, say, Sputnik and Sinopharm and Sinovac, and that's great, but it's also important to remember that there are a lot more vaccines that are coming down the pipe that are either in later stage clinical trials, earlier stage clinical trials, vaccines that are probably going to be licensed fairly soon. And the more vaccines that we have, the more licensed vaccines. Well, first of all, it's just more vaccines that will be available, which is great. But it also just there's a lot more opportunities for sort of global equitable vaccine distribution. The more vaccines that you have, and so it's not necessarily like this is going to all of a sudden make it all work or all better, but it is a positive thing. And I guess the last sort of positive component and something else to keep in mind is something that might help change, but the you know there are a lot of efforts that are going on right now that are really trying to raise awareness of what's going on, raise awareness of why this is such a critical problem, both for individual countries as well as globally. And so, I'll just, pitch very quickly that on the 24th, so just coming up in a couple days, there's a big international meeting that's hosted by the Zero COVID Coalition of the UK and the Zero COVID Alliance that is an entire event that's called the Need for a People's Vaccine and the Fight for Vaccine Equity. And there are lots of talks about how vaccine equity can be achieved, how to sort of bridge all those hurdles, those gaps and those hurdles that we've been talking about, and really, why this is so important and what individual people can do. Because, any person, you can see, okay, is your country supporting, for example, the vaccine patent waiver? Well, if not, you can go, you can fill out a letter, you can be petitioning that, to come out in support of that. So it's a long hurdle, it's a long fight, but it's also, there's progress being made, and there are so many opportunities for everybody to get involved in helping to push for global vaccine equity.
Would you say at this point that in most places where they're still hesitant to get rid of the patents, that it's probably just lobbying interest?
I think lobbying interest is probably playing a huge role. I would not be surprised at all. I can't, again, that's another area that's definitely out of my area of expertise. But yeah, that would, I think lobbying efforts would probably be playing a fairly significant role. Very, very possible.
Cool. Well, I think that's left a lot for everybody to think about. Thanks for coming on again, Jeremy, and we'll have to do this again.
My pleasure, and hopefully we'll have some, better global news, better equitable news that we can talk about.
Cool. Sounds good.
Thank you.
Oh, and I'm assuming that you're still not on social media or anything like that. So if people want to find you, they got to just start walking around the streets of Chicago and
exactly
that way. Yeah. Okay, so there you go, folks. Just walk around Chicago, and
there you go.
You'll eventually find a nicely bearded man, and you can fuck him there.
It's very possible. Good luck.
Thanks for listening to this episode. The music you hear on this show is from the Jeff Lapp Trio out of Montreal. Find them at jefflapp.com. Shout out to Tara for doing the graphics for COVID On Air. A huge thanks to my editor Jeff at Bean Co. Studios in Regina, Saskatchewan. Please visit endcoronavirus.org for more information on ECV. Click on Join Us. Through that, you can volunteer with ECV, and you can subscribe to our newsletter, which is full of great information shot straight to your inbox from our delightful newsletter editor, Tracy. Also, please check out the blog at ECV, and hats off to Scott, our impeccable blog editor. You can find ECV on Facebook and Instagram and on Twitter at NCovid19. You can find me on Twitter at Mr. Farden. It's at MrFarden. Until next time.